welcome to On Becoming a Healer. In 2021, a young mother in Alabama gave birth and was shortly thereafter charged with a felony. In fact, this young mother had been receiving prescribed opioids from her orthopedist for a long-term pain condition. And at the time that she gave birth, she was tested for presence of opioids, and they found evidence that she was receiving them in her system or in the infant. I'm not sure which. She had not proactively disclosed to her orthopedic doctor that she was pregnant during the prior months. And that was the seedbed of a felony charge of fraud. The State Department of Child Protective Services found no harm to her or to her baby and didn't feel there was an issue to be pursued. But the local prosecutor felt that this was a big issue. Ultimately, after a considerable degree of publicity, the charges were dropped, but nonetheless, it left me very confused and puzzled about what's going on when people who give birth are potentially charged with a crime or have their family broken up as a result of a test done. Today, we're going to be talking about the dilemmas we face when caring for people who have given birth, particularly when drug tests are involved, and the care of both the person who gave birth and the baby can change immensely depending on the results in the hospital. And for that reason, we do have a special guest, Dr. Mishka Terplan, who I'm going to introduce in a moment. But Saul, I wonder if you can connect this topic to the themes of our podcast and why we're having this conversation at this time.
The theme that I think is going to emerge, I believe, from today's episode ties back to a couple of earlier episodes that we did. If you may recall, we had one on urine drug testing in patients who have opioid use disorder or just opioid users. That one was in August of 2022. It was with Michael Incy, and it was called Urine Drug Testing, How It Can Traumatize Patients and Undermine the Physician-Patient Relationship Without Helping Anyone. And if you recall, we featured a story that our guest had written about in which a patient had been incarcerated and then released and had this phobia associated with kind of urine drug testing because he'd used it in a punitive way, even at the time when he was on parole. And when he came in for a visit and ended up seeing a different doctor because our guest was away, he basically was forced to have his urine tested. It came back positive. He was extremely upset. It was just a screening test, and he demanded to have a confirmatory test done just because he was so upset. And actually, our guest said to him, don't worry about it. I'm not going to pay any attention to this anyway. But it was an example of how he felt demeaned by what had been done to him. And it also brought up a theme, which I think we're going to talk about today, which is how these screening tests are actually not very accurate. The other episode that I think this is connected to, the one that we're going to do today, is an interview that we did with Larry Haber in August last year called My Patients in Shackles, Can We Take Them Off? In that particular episode, we discussed a case of a patient who was intubated, sedated, and in shackles in the intensive care unit. And that really stood out for me because you just can't justify under any rational grounds tying someone up under those conditions. So in today's episode, our guest is going to be talking about, urine drug screening in the context of people who are pregnant. But I think an overarching theme, which I think is critical for our On Becoming a Healer mission, is how physicians can get co-opted by the state in a punitive process that harms patients, disproportionately those from marginalized groups. And I think that as physicians, we are often, I think at times, naive about how we can get pulled into structural racism, into harming people who we want to care about and care for, and also how we often live in a world of ambiguity. As you'll see, the policies are often a little vague, confusing. They vary from state to state. We're not sure what to do. We want to, quote, be on the safe side, so we order the test. We don't take the shackles off, etc., and we end up doing harm. And so I think today's episode is going to explore that. Before I turn it back to you, I just want to read something that our guest wrote that I think kind of gets at the crux of what I'm hoping we'll reflect on today. He wrote, drug use during pregnancy differs little by race and class, yet people who are poor, Black, or from other historically underrepresented and underserved communities are more likely to be tested, reported to child welfare, have a child placed in foster care, and have their parental rights terminated. This disproportionate testing results from the reproduction of structural relations of oppression within the clinical encounter. Physicians are more verbally dominant and less person-centered when talking with Black than with white patients, a dynamic likely present across clinical encounters among individuals with other identities that have been rendered marginal, which includes pregnant people who use drugs.
So, with that introduction, let me say Dr. Mishka Terplan is board certified in obstetrics and gynecology and in addiction medicine. His primary clinical research, public health, and advocacy interests lie at the intersection of reproductive and behavioral health. Dr. Terplan has published extensively on healthcare inequities, on discrimination, on access to treatment. He has played a role in guidance documents developed by the American Congress of Obstetrician Gynecologists, the American Society of Addiction Medicine, and the Substance Abuse and Mental Health Services Administration. He's participated in countless expert panels, both at the federal level and even with the United Nations. Dr. Terplan works with the Friends Research Institute and is adjunct faculty at the University of California at San Francisco. Hello, Dr. Terplan.
Hello. Thank you so much for having me.
Can I call you Mishka?
Please, yes.
Okay, that's great. What we're going to do initially is just lay out some of the basic facts so that everybody is on the same page. The real concern here that motivated my concern with the story I described, we're interested in biological tests used at the time of birth that look for evidence of drug use. What are these tests? What is actually tested? What's ordered?
Well, you mentioned earlier, and I want to maybe just begin by clarifying some definitions.
Sure.
So when we say the word test, we mean that we're looking at a biological sample for the presence or absence of parent compounds or oftentimes drug metabolites. And that sample can be, urine, blood, meconium would be, the primary ones, during the birthing hospitalization, but there's other people can look at sweat and hair follicles and stuff like that too. And that's testing. And it captures presence or absence of particular compounds at a particular moment in time. And we contrast that with screening, which is the use of a validated instrument and or having a conversation with a person that actually captures, behaviors and gives you more information. And so what is recommended across professional societies and public health organizations is screening. We think of behavioral health as an integral part of health and wellness, and assessment of behavioral health as part of routine, care, including prenatal care and during the birthing hospitalization through screening, through talking to a person or using a validated instrument. Testing, it's totally clear from, professional societies and et cetera, that testing is an inappropriate way to measure whether or not somebody has a substance use disorder and is actually what's not recommended for the assessment of substance use and use disorder during the birthing hospitalization. And as I think we will expand on, there are many problems, with the use and really overuse and misinterpretation of drug tests at the time of birth.
In the case I described, the mother who had given birth received a biological test. I don't know if she was asked whether she wanted to have that happen, but I am curious, do we know if there are states or other jurisdictions that actually require testing biologically under all conditions, or is that never required?
So there is huge heterogeneity in terms of state-specific policies around this. But overall, there are very, very few states that actually require drug testing. For example, Minnesota has a law on the books that if a physician admits somebody in labor, they must get a drug test. But that's one of the exceptions. Almost every other state does not specify in state law that a drug test is required. What tends to be required or oftentimes also overinterpreted or misinterpreted by health professionals is what you do with a positive result. So one way to avoid over-reporting to child welfare, or in your circumstance, that's a sequence of events that's actually taking place, originated within the healthcare setting, but is really happening in the criminal legal space. It is just like critically thinking about why we're doing a drug test.
So it sounds like there may be some doctors, some hospitals, some clinics that either ask an oral set of questions about potential exposure and then just order a drug test based on what the mother might respond. Is that possible?
Well, I just described very superficially what the state policy landscape is. But hospitals also have policies. And not everyone who works in the hospital actually even knows what the policies are. So there are some hospitals that have policies around drug testing. There are more hospitals that people who work there think there's a policy around drug testing. There are many providers who think that, drug testing is required by child welfare. And so so this reflects sort of misunderstanding. I would even verge to say ignorance on the part of providers, and more importantly, reflects like an interesting, I don't know exactly how to say this, but it's like a behavioral default setting amongst health professionals. The default being like, I don't really know what the law is. I might think I know what the law is, but in the absence of knowing, I'm going to test. Now, I also don't know what to do with how to interpret the result or what to do with that information, but in same thing, in the absence of knowing, my default setting is going to be testing and reporting and not understanding what the consequences of that report, are to that person, to her child, to her family, and as that quote illustrated to some extent, to that community and the historical trauma that we can reproduce and perpetuate.
So you have a set of doctors and potential other healthcare personnel who default to doing something that might not be required. And I actually recall a story that several Alabama hospitals were reported in 2015 of quietly testing mothers without actually informing them at all that they were ordering those tests. Although many hospitals then were asked about their policies and declined to provide them to the reporting agency, which was ProPublica. The doctors are afraid. Now, maybe they think they're doing the right thing. If I talk to a patient who's about to give birth and they do tell me, hey, I used cocaine 3 weeks ago, is there any reason that I should order a drug test today?
Well, I think the question for any clinical care, but especially drug tests versus to some extent screening, is how is this information going to improve the care of the person that's sitting in front of me? And what am I going to do, with that piece of information beyond that immediate setting? So if the reason for either talking or testing people at the time of birth is to identify people who might have untreated use disorder and thereby refer them to treatment, then, we know a drug test is not the appropriate tool. Addiction's a behavioral condition, brain-centered. The symptoms of addiction are behaviors. There's nothing in a drug test that tells you anything about behaviors. Generally speaking, we're actually using the drug test at birth as kind of a moral test, but certainly as a parenting test. And that's completely, inappropriate. And that's us exerting, sort of reproducing normative, structural discrimination and differentiating some folks from not having a right to parent versus others that do. So for this case, this example of the person who self-reports recent cocaine use, that's not where the clinical encounter should stop. So what you need to do is figure out, do they have a use disorder or not? Walk through the diagnostic criteria, or even just ask them, is this something that you are worried about for yourself, for your pregnancy, for your baby to be? Would you be interested in treatment? And if somebody's interested in treatment, somewhere it doesn't matter what their diagnostic, whether or not they meet diagnostic criteria. But in the very least, that's usually the pathway is your screening test positive, but you need a diagnostic test to kind of take the next step. So it's really, what are you going, and then who are you going to share that information with? And that is another piece of this story, has to do with really the porousness of clinical encounters to policing structures. And that I would include not just the person who was perhaps, dragged out of her home by the sheriffs, but I would include child welfare, which is also been described legitimately as family policing, underneath that organization. So how information moved, from the clinical to the carceral spaces is something I think we need to be more attentive to.
So you said that very carefully, but I'm going to respond like probably John Q. Public and more than a few doctors. gosh, babies could be at risk if the mom has severe addiction. We got to be really worried, and we got to have people looking in on making sure that nothing goes wrong, because some mothers who use drugs aren't capable of being good parents. I don't want that to happen to some innocent baby out there. And that's why we all have a collective interest in making sure that we know exactly who used drugs before they gave birth. What do you say to that?
Well, I mean, I think I'd want to split out a couple of different potential consequences of in utero substance exposure.
Okay.
Because you focused on sort of a parenting piece, and and that might be the most salient of the different sort of strands of response that happen, across scientific publications, but in particular, sort of like the public media. But the main one, the more common one, I think, is that drugs are harmful.
That's the belief.
Yeah, and illegal drugs are more harmful than legal ones, and anything that causes an addiction is probably more harmful than something that can be prescribed, that is prescribed and controlled in that fashion. And that's, to me, so that's incorrect, from a developmental perspective.
Okay.
And it really, just thinking about, for example, this is more specific, but just thinking about teratogens, substances that can cause birth defects, right? None of the drugs classified as illegal are teratogenic. Alcohol is the leading cause of preventable intellectual disability in the United States as a legal substance. Oh. Nicotine in animal models people sometimes refer to it as a neuroteratogen, but it's unclear how that really applies to human health. And then most of the known teratogens are actually substances that are prescribed, that are controlled and some of them are ones we actually use in pregnancy. There are no anti-epileptic medications that are not teratogenic. And sometimes people need more than one, but we know that treated seizure disorder improves maternal health, improves newborn outcomes more than untreated seizure disorders do. So what we do when we assume that an in utero exposure to cocaine is like bad, harmful, what we're really doing is applying sort of the ideology or the logic in quotation marks of the classification of drugs through drug policy, which is sociological and legal. We're applying that classification to biological phenomenon and public health. And that's incorrect. That is, that system of classification is not a system of classification if we were going to rank harms.
So if the harms are perhaps greater with alcohol, maybe tangible with nicotine, we're not really sure, maybe lesser with cocaine, I have to play this out. So would you argue that when you test all mothers for alcohol metabolite exposure and for nicotine, and perhaps report all the mothers who smoke and all the mothers who drink and all the mothers who acknowledge cocaine use or test positive to child welfare protection agencies?
I mean, I'm just going to play one thing. And then the other concern, relates not just to that teratogens and birth outcomes.
Oh, yes.
But I touched on this with alcohol would be like, neurocognitive behavioral development of the infant and child. Right. And this is where some of the data get like a little bit trickier. Like we know the closer you are to birth, the data that measures things closer to birth, we have more data there. And as you move out in time, we have fewer prospective studies. Stuff is cross-sectional. There's all sorts of, sort of confounding, measured or unmeasured. But more importantly, like what happens is like even in these cross-sectional studies is, you see there's a study that looks at test performances, a high school test performance based upon whether or not the infant had newborn withdrawal from opioids or not. And they found an association. And nothing else is measured in that, between birth and high school. And that's a very common kind of conclusion from those data that people reach. And that's an example of, sort of like the single cause fallacy. You're attributing one thing just to the single cause. And that's incredibly common in this space. And that also, I would say, reflects this sort of drug war ideology, this prohibitionist logic, that's, applied to this particular circumstance. Because if you're really concerned about development, right, there's, just lead, right? Lead exposure.
Lead.
Lead. Flint, Michigan. Lead is a huge problem in like older housing stock in the United States, and has well described behavioral developmental consequences of far greater magnitude than any illegal substance. So we have this hysteria over drugs that does not correlate with the reality of environmental toxins that pregnant people and infants and young children are exposed to in our, society.
Yeah, so there's a disproportionate response. And I think the lead example is a very interesting one. So I think you've made the case at this point that the attention to the illegal drugs is probably not driven by rational medical assessment. And I can mention here that roughly 500,000 U.S. children have unsafe lead levels. There are 3,000 areas in the United States that have lead exposure rates greater than that of Flint, Michigan. There's not much being done about that, actually, in a lot of communities. So there's a logic or an illogic to our current response. But let's just now step back and ask, okay, maybe we shouldn't have ordered those tests, but somebody else did. Somebody else put it on, and I'm the doctor, and I now see a result. And I'm not even convinced that that positive test for amphetamine is credible. I understood that I was required to report to the state the result, even if I don't believe it, just to be on the safe side. What does federal law require, and what do states require?
Well, it also varies. And at the federal level, so all the state statutes are in response to a federal law called CAPTA, the Child Abuse Prevention Treatment Act. Dates from the early 1970s. It's where what we're really talking about here is mandatory reporting.
Yes.
And this is where sort of mandatory reporting gets articulated in federal statute for the first time, is under CAPTA. Do note that at that point in time, in the early 1970s, there was mandatory reporting laws in every single state for child abuse. And initially, it's framed around child abuse. I mean, it still is, but that was the primary thing. And this might be too much detail, but I think some of this sort of architecture of the child abuse response is important to understand to problematize the sort of current regime of mandated reporting for substance exposure. So when you think child abuse, there is a potential serious safety concern for the newborn. And so decisions need to be made quickly. So under CAPTA, once a report is sort of verified or substantiated, a 72-hour period, within 72 hours, there needs to be a hearing to decide placement of the child. And that's driven from this, like I said, legitimate concern for child abuse and potentially having to remove a child from a home in which the child is being physically, emotionally, or sexually, abused. Nothing in the original CAPTA language has anything to do with drugs. There's multiple, reauthorizations that happen through its now almost 50-year lifetime. And really, it's following the hysteria around crack babies, which there's no such thing as a crack baby.
Turned out to be, that's total bunk, as it turned out.
It's a whole nother, it's really in some ways the lodestone for the cases that and everything around this. But following sort of the media and scientific hysteria around crack babies, drugs start to enter into the CAPTA reauthorization language. So, for example, when I was a medical student in the 1990s, there was some drug testing. There was no reporting, for substance-exposed newborns. When I was on a fellow and, junior faculty in the early 2000s, it wasn't until like the mid-2000s that I started, noticing this happening. And it was a consequence of the changes in the federal law. So what the federal law has said for the last 10 years is, and some of the language has changed, but where it stands now, you need to report an infant who has been, quote, affected by, and that's the operant term, like withdrawal, substance exposure, et cetera. And that is a vague term. And many people don't like that vagueness. I actually, a minority opinion, and it was affected by illicit drug use, then withdrawal, then alcohol got put in there too, like for good reasons, for the reasons I said, it's the leading cause of preventable intellectual disability in the United States. Early intervention works. If we can identify people early and get them home visiting and other supports, the secondary consequences of, fetal alcohol exposure are lessened. So there's a public health motivation for that. But in reality, this language just has contributed, to over testing and over reporting. And that's, kind of really taken off in the past, 10, 15 years of, the opioid crisis.
Because once there's language that says we must report if they're affected by, that creates some incentive to test more, doesn't it?
Well, I like affected by, like I said, it's a minority opinion, I think, because it implies more than a drug test to me.
Sure.
It implies some clinical assessment, right? Is this infant affected by?
Sure.
What does that mean? It's,
that
do they
true.
have it, sign of a birth defect affected by, or is there some measurable, it's something significant to me. But most people interpret that as, a positive drug test, which could be a false positive drug test.
And just to lay this out at the state level, if I understand from the latest report from the Guttmacher Institute, 26 states and the District of Columbia will require reporting suspected use of drugs by the person who gives birth, which means that there's no more affected by determination. So if I think there was use of a drug, although apparently not alcohol, I'm mandated to report if I live in one of those 26 states. Do you think that's an accurate statement?
So the language of state statutes differ. They tend to mimic the affected by on the whole, but generally speaking, as you go from the federal to the state to the local hospital, and then even sometimes to the individual providers in the local hospital, stuff gets more restricted or conservative, or the space of reporting gets larger.
And what are the consequences? I mean, one of the reasons I was curious to speak to you is that I listened to you in a session at a meeting in which the child welfare agencies that intervene weren't seen as entirely friendly, helpful, or supportive of parenting, which I wound up confused. I simultaneously have in my head the notion that child welfare protective agencies come in and do good. And I have in my head at the very same time a storyline in which is they come on and they upend families. And I'm totally confused about how to make sense of that. But what really happens when we report?
I mean, I think you're speaking to one of the reasons people report, which is, and I think, a misunderstanding of what the child welfare system is, both historically and contemporarily. And one of the reasons people have to report is I see here's a family that needs services, needs some sort of help. I don't know how to do that help.
Yeah.
I work in a hospital, which is perhaps the most resourced place in this entire community, and the hospital isn't helping these people. Separate issue that needs to be addressed. Therefore, I'm going to report them to this agency that I don't know very much about, but I assume is a service provider. But it's not.
Yeah.
It's a surveillance agency.
Huh. Well, lay that out. Why are they surveillance and maybe not so much a help?
I mean, there are parts, and child welfare people would push back on that statement. And some of that pushback would be legitimate. There's been a growth of what they call preventive services within child welfare. But generally speaking, let's maybe just from the perspective of somebody with a use disorder. They're not a service provider. They don't provide treatment. They're not behavioral health specialists who work within child welfare agencies. They can mandate services, but they do not provide services. They don't provide transportation to services. They don't provide, sort of quality, of anything. And generally speaking, they tend to think about addiction in the most unsophisticated, rudimentary, general population kind of way, which is abstinence-based. And no nuance about recovery. Recovery is a destination that's defined by abstinence. It's not a process. And overstate, the risk of these, chemical exposures of illicit substances to newborns. And really minimize, I think, the importance of attachment and stability of the dyad, which is critical for early childhood development. So they're not a service agency, they're a surveillance agency. What happens is there's a report that's made. The report is either screened in or screened out. Many states have laws that say that if the report is for substance exposure, it must be screened in. So you can't be screened out. Once it's screened in, there's an investigation that oftentimes involves a home visit. The home visit, there's this really incredible pediatrician named Hallam Hurt who still does wonderful research, did critical research in the 90s and early 2000s around cocaine exposure. And I'm going to go on a detour for her for a second. And so she was one of the first people to get a NIDA grant to look at the developmental consequences of in utero cocaine exposure. And her hypothesis, common at the time, was that kids exposed to cocaine in utero would have decreased IQ at 2 years of age. 2 years of age, data matured, they looked at it. There was no difference by cocaine. Almost all of the study participants were Black who lived in extreme poverty in, segregated West Philly. What she noticed, though, was there was a range of IQ in both the cocaine and unexposed groups. Went from above average to low. And so her research starts to shift kind of from drug to development. She starts so what is it about these environments? And she called, I don't like this turn of phrase, but she called them inner city high achievers or something like that. But what is it that, what is unique to the care environment for those kids who have the higher IQ? And she started doing home visits. And she operationalized the home environment. She looked at things like the physical environment. She looked at language, interactive language. She looked at learning. She looked at books and other sorts of things in the physical environment. What she found was that language stimulation, learning stimulation were associated with higher IQ. The physical environment, there was no association between, rugs on the floor, light bulbs versus covered lights or, all that sort of stuff. Now, what is home? When a child welfare worker goes into somebody's home, they're actually looking almost exclusively at the physical environment. The one thing we know that is not associated with development. So then after the home visit, people are put on a decision, there's that hearing, kid stays, not stays in the home, and they stay under surveillance. The family stays under surveillance. The child might be removed, and then they're both under surveillance, separate, until the case is closed. So that's why we call it a surveillance system, not a service provider.
And one of the things I did catch in the reading preparing for this is that because the physical environment of the infant and child are given so much priority, there are two very common outcomes. One is that real poverty is seen as an indication of mistreatment or abuse of the child, and real poverty can result in loss of the child, which would seem really disparate and different from a concern about mistreatment of that child by the parent. Is that what you've seen as well?
Yeah, so the number one cause for removal is neglect.
Yeah, that's the word that's used, but what does that mean?
Good question. It basically is a big bucket in which you can justify discrimination and prejudice. And it just kind of means poverty. It means it's more likely to be poverty of people who are different than me. It can mean immigration status, language status, ability status, all sorts of things get dropped into there. And the second leading cause, this is for all children, of removal. It's about 60% of removals of all children are for neglect. About 30% are for drug use. If you look at infants, though, so that's within the first year of life, actually, it varies by state, but on average in the United States, over 50% of all infant removals are for drug use. And there's some states where it's 60, 70%. So the main driver right now of the foster system is drugs, or drugs in quotation marks. This and primarily amongst infants, all of that is initiating during the birthing hospitalization.
So we're in the middle of right now what's called an opioid crisis. I have confusion about what word to use, but I'm sure that there are a meaningfully large number of people who give birth who newborn has to go through treatment or management of some kind for neonatal abstinence syndrome. They have some temporary withdrawal symptoms. It's not usually dangerous to that infant. But I can imagine that there now then folds a question of how do we make sure that the mother goes into some sort of, quote, treatment program, and how do we protect the infant? Do you think that it's a good idea to just sort of remove all those infants until those mothers, quote, get clean?
Definitely not. But I think this is actually a good time to bring up another important distinction that gets lost in mandated reporting and talking about pregnant and parenting people who use drugs, which is the distinction between treated and untreated use disorder.
Okay.
And neonatal abstinence syndrome illustrates this really well. There's really three populations of infants that can develop withdrawal. People who are prescribed opioids for a chronic condition who do not have an opioid use disorder, people with untreated opioid use disorder, and people with opioid use disorder that's treated with either methadone or buprenorphine. Those are three different populations. A drug test does not distinguish those three populations. There are, potentially, those three populations need different things in the early newborn care period. And people may, or not report differently based upon those categories too. But just looking at the drug alone, you lose all of that important nuance and difference that is super meaningful in the care and that needs to be provided. So many of these, like the insertion of withdrawal into the CAPTA reauthorization in like 2011 or whenever it was, led to people who were stable in recovery, receiving medications for opioid use disorder, whose infants experienced withdrawal being reported into the system.
Yeah, the infant is in withdrawal. So the system says we have to report because they've been affected by substance use. They've been affected by substance use because the person who just gave birth is doing the right things to stay stable, to take good care of their kid. But now, because they've done those things, if I understand it, they're likely to have to go to a hearing, maybe go to parenting classes, maybe go to anger management, and maybe go to court to protect their right to take care of their kid. Is that plausibly true? And is that something that's happening?
Oh, yeah. And they're at risk of losing the child. Yeah. And I don't know when. There's never a good time to talk about maternal mortality, but I'll just say we have also a crisis of maternal deaths in the United States. Some of those deaths are due to racism, both like provider level racism as well as structural racism. Many of those deaths are also due to overdose. There are some states where overdose is the leading cause of maternal deaths. Almost all of those deaths are happening in the postpartum period, not during pregnancy. And some of those deaths are related to child welfare involvement. This is now more anecdotal and qualitative data rather than population science that I'm saying. But, somebody's child is removed. That can be a return to use, which can lead to overdose and to overdose death. So this, sort of punitive system has measurable population, harm.
So I'm a doctor, and we're going to turn to Saul right now, but just to set it up, I'm a doctor. The state has a lot of rules. The federal government has a lot of rules. Sometimes I just veer toward adopting whatever is the most conservative version of that, because apparently the thing I care about is keeping my license and not even having to think about it. But sometimes in the act of honoring what I think are the rules, I could cause trauma to my patient, trauma to their child, and maybe even precipitate the conditions that cause the death of my patient. So suddenly my responsibilities are beginning to feel confusing to me. And with that, I'd like to ask Saul to bring this into the theme of this podcast, which is on becoming a healer. And how am I supposed to manage my fears about being a good healer versus keeping up with the rules?
Thank you. In fact, on that note, I'd like to just start with a couple of follow-up questions that get at that for Mishka. So first of all, Mishka, are there situations where you actually do want to order some sort of urine drug test?
So I will say that many hospitals, mostly due to the younger generation of providers, who are coming into medicine more humanistically grounded, greater understanding of social justice, and a different understanding of what the work of healing is compared to many of my the people that I trained with. So policies are changing, and there are people who are critically thinking about this and making local changes. And the question I always ask is, and I think the answer differs a little bit by place, but when is a drug test clinically indicated? People have come up with different answers. I mean, the only one that I really have is not unique to pregnancy, but if somebody's obtunded or altered and you don't know what's going on, a drug test can give you some information that you can act on. And also, as an addiction medicine provider, we use drug tests all the time in addiction treatment. So it's not a great test, but it's also it's neither good nor evil. It's a tool. And it's really the more important thing is thinking how we use it. How we use it is what gives it meaning and value. And we can use it well, or we can use it poorly. And I think so that would be reflected in, certain circumstances. So I'm not trying to indicate I categorically opposed to drug testing.
Thank you. My second question is, are you aware of a physician ever getting in trouble for not ordering a drug test, not reporting a positive drug test to a state institution?
Never
happened.
And it's not just me, my own personal experience. This is in conversations with, lawyers and other physicians in my network, that I've never heard of a physician being penalized. I've actually never heard of a nurse being penalized at the level of state licensure. I've never heard of a social worker being penalized. And I will say, though, that even though we're talking about drug testing and responsibility, generally speaking, I've never reported anyone. I've had patients who were reported. It's rarely it sometimes is the physician who reports, or the physician who strong arms the social worker who reports, but it tends to be today the primary responsibility of the social workers, who intersect with labor and delivery and postpartum. Saying that there's, no consequence is, I also want to acknowledge, reflects my sort of place and privilege as a physician, as a professor, as a director of a clinical system. I don't get into that kind of trouble, right? But I've worked with social workers who are more junior, who report to the lead social worker, and the lead social worker has been like, why didn't you report this person? And it's come up in their, annual evaluations. So I wouldn't say it's without any kind of potential consequence, but I want to contrast that consequence with what the consequence of the report is to the pregnant or parenting person, her child, and her family, which is far more enormous.
I think what we can safely say is that we as physicians can actually do the right thing. And the right thing is to preserve that dyad between the mother and the child, and fundamentally, to be guided by our partnership with our patient. And that's sort of the essence of, I think, what we like to talk about on becoming a healer, which is that engaging with a person who we have, who we're privileged to get to know, to help, to problem solve with together, is what guides us. And now, that doesn't mean we won't, quote, occasionally get burned, which is something physicians worry about, but that's not the goal here. The goal is not to not occasionally get burned. The goal is to be open-hearted and caring, and to realize that that trusting approach is going to yield you the best results the vast majority of time. So for instance, if you're surveying a patient for substance use, and again, that's not a blood test, it's a conversation, it's a set of questions, you're most likely to get a truthful response if that person feels like they can trust you. And I think that the conversation that you guys have just been having has been in the weeds for a good reason. Stefan's been...
Because I'm always in the weeds, Saul.
Stefan's been asking a lot of kind of detailed questions that I think we all needed to hear in order to understand that there really isn't a basis for this obsession with testing, for this chronic fear that I could get in trouble, that I got to be safe. It's so important to expose that because so many physicians feel it. And again, it's something that we've addressed in other episodes. I think it's also so important to recognize that there is a historical basis that is entrenched in racism and attacks on marginalized groups with terms like crack baby. These things didn't emerge out of nowhere. They were created. These are racist ideas which supported racist policies, and that many of us who are physicians at this point may not even be aware of that, depending on how old we are, how young we are. But we've been affected by them. They affect our behavior, and we can become co-opted by the state to be, unfortunately, bad actors, to be enforcers of racist policies, of harmful policies, without realizing that that's what we're doing. And I think that that's something that's just emerging. And again, the answer is always to fall back on caring about that person who you've been entrusted to care for. I'd love to know, Mishka, if that framework of grounding what guides us in the relationship that we have with our patient is one that you share.
I agree. This makes me think a little bit about the idea of centering. And really the idea of centering that comes from like the reproductive justice movement, which is founded and articulated by Black feminists and relates to sort of values and the values being, and it's that space between human rights and social justice, like how you get to social justice from a human rights framework. And, the right to parent, the right not to parent, and somewhere the most critical is the right to raise children in safe and sustainable environments. And that's the part that I think really stands out and contributes ethically and more to this conversation. And how you do that, and what reproductive justice folks talk about is centering on, the most vulnerable. And that's something that happens or can happen sort of in the clinical encounter. You hold the people you serve first and foremost. But it can also happen in how we develop policies and how we do the work of public health. And it begins by, bringing people into the decision-making process, but more really supporting them and centering the work that we do around that. And there's good examples of community-based organizations, some of which have partnered with health institutions that are trying to do this work. And it's really articulating what do people need. And who knows what they need the most are the people who need the stuff, not us. My assumptions about what somebody needs aren't always what they need. And so I think what you're describing is, sort of centering on those that have been rendered most marginal. And it doesn't just improve them and their community, it actually improves all of us. And that's the other thing too, right? That's the other piece of the big picture of health inequity, is that health inequities clearly are harmful to those who are most impacted. But health inequities also harm everybody else in the society.
How so?
Well, so people look at this as like Michael Marmot, and I can't remember his colleague's name right now, like the UK data, looking at income inequality.
Yes.
The greater the income inequality, the worse the health outcomes, certainly for people on the lower end of the income spectrum, but also in the middle and the higher ends of the income. And we know this from early childhood development too. There's a whole science of early childhood development that is not integrated into the functionality of the family policing system or that well integrated into the healthcare services we provide. There's data, UN cross-cultural data, that actually environments that are more unequal by income or other things worsen child developmental outcomes for all infants, not just those at the lower end of whatever the measured spectrum are. So inequality is harmful, not just for poor people, but for everybody, actually. I'm not trying to minimize the health effects of inequality on people in extreme poverty, but want to connect it to the income, perhaps, of the people who are the service providers.
I find this conversation reassuring to the style in which I like to practice. I find it liberating to know that I can walk into a patient's room and close the door, and all I need to do is think about how can this person and me problem solve together? How can we partner to figure out how to move forward? What's going to be best for them and for their child, and just tune out all the noise. You call that centering, I call it engagement. That's what makes practicing medicine rich and meaningful.
Yeah, I hear you. And I don't disagree with that. But I also think it's insufficient and could be seen as naive in that, so a couple of things. There's something in particular around drugs and in general, but drugs and pregnancy. I think the clinical environment is one of mutual mistrust. Right? How we're trained to not believe people who use drugs.
Yes, we are.
The only training I got in medical school was you ask somebody how much they drink and just double it if you want to know the real answer. And we have this other phrase like denial is a symptom of addiction. That's a way of, minimizing what people tell us. It's a form of mistrust. And patients have mistrust too. And I would say their contrast to ours, their mistrust is legitimate. It's born from experiences of healthcare discrimination. It's born from the knowledge of what disclosure might mean in terms of their ability to parent the child, that they have or that they're pregnant with. It's born also from sort of a historical memory and intergenerational trauma. And there's a power differential in healthcare. And that power differential, I think, reflects a responsibility in relationship to mistrust. The responsibility for overcoming mistrust rests on us, not on the patient. But how often do I hear, she wasn't being honest with me, or we're going to get a drug test because I don't believe her? We have to have the responsibility to create environments which are safe and welcoming for disclosure. And I'll be perfectly frank, I am not sure that we can do that right now. I can tell my patients, I'm not going to report you. If you get reported, let me know. I will follow you into family court. And I have, and I do. But I can't control that flow of information from the electronic health record to child welfare, or Stefan, in your case, to the local prosecutor.
Yeah. So Saul, you've been accused of almost a tiny bit of naivete, not in an aggressive way, but I was having the same reaction, which was, Saul wants to close that door because it should be a protected space, and it really should be. And yet there is this, and I personally am always worried about who's right outside the door, me speaking for myself. And I guess Mishka's saying there is something outside the door, and that thing is impacting you or the patient almost despite your best wishes. Is that correct? And do you think that's right, Saul?
So what I would say, if I'm interpreting Mishka's comments correctly, is that we have to recognize that there is such a toxic environment that we're working in, that when we, quote, close that door and start to have this conversation with a patient with a genuine sense of shared humanity, an openness to be helpful to them in whatever way we can, we have to be aware of a couple things. One is they still may not trust us for good reason because of the life experience that they've had. And secondly, we have to recognize that even if we are trustworthy, there are still bad things that can happen to them in the process of seeking care. For example, as you said, somebody could audit the medical record. And so I think I have two thoughts about that. So for the latter, I think part of what we do is that we have to be allies of patients and say, hey, by the way, I just need you to know that while this would never happen coming from me, there are some things we have to be worried about. I'm going to do everything I can do to protect you. Then the second thing is recognizing that they may have a legitimately difficult time trusting us, no matter how trustworthy we are. And I think that that's just a sad reality of the current situation that we can't necessarily change. But it doesn't mean that we should do anything other than be true allies, people who care, people who are there to problem solve, even if it takes a while and maybe is never possible for a patient to fully trust us. I can't change what the patient is feeling and what they're thinking because of their lived experience, but I can certainly choose to be a caring, non-judgmental person who wants to have a helpful and caring relationship with this person who has come to me for medical care. And that's what makes my work meaningful and what can be my true north, what guides me. That's going to guide me. It's going to be my sense of what my values are and what I find when I connect with another person or try to connect with a person. That's what's going to guide me. And, I stand by that with the understanding that that doesn't mean that everything is going to be rosy. Is that helpful, Mishka, the way I'm reframing it?
Yeah, I would say, I think, Stefan, you keyed into this idea of closing the door. And that image is like cutting, sort of artificially separating clinical care from the social context in which it happens. or the historical and social structures in which we're all embedded. And some of the sort of the mental processes I was talking about earlier, how we've really like internalized prohibitionist drug policy and we apply it uncritically to both the production of science, the interpretation of science, the interpretation of clinical like encounters, and that can lead to reporting, for example. So we not only when we close the door, we artificially separate from society, but we also bring stuff with us. More importantly, though, I think it points to that the clinical encounter is insufficient for affecting social change,
Sure.
or for even sometimes improving the health and well-being of the people that we serve. And I think everybody probably answers this question differently, but it speaks to what the responsibility of, let's just say, physicians are beyond the clinic. What is our responsibility and what is our training in that? I have a lot of reasons to have like a whole bunch of privilege, including I don't have kids. My job is like everything to me. And so it's been much easier for me than for other people to follow my patients into family court, to write letters, on nights and weekends to judges and child welfare workers. And I've learned most of my knowledge around, family policing like exclusively came initially from following the people that I care for into the court system. And more recently has come from like my own research and reading and stuff like that. But what is our responsibility beyond the clinic? There's a lot of doctors who are out there trying to change some of these state policies, these punitive state policies. How do we train people to do that correctly? How do we support them to do it? What does it mean if we're advocating for social change, but the institution we work for is one of the leading causes of the inequities that we're seeing? There's all this attention to like provider burnout and the idea of moral injury. I'm very sympathetic to providers who are working within health systems that do not align with their values.
Yeah.
Which is like the definition of moral injury. And this is happening in particular around this like drug test and report at birth.
Yeah. And that's why I've been anxious throughout this whole conversation. Saul, help us out further if you can.
So before we turned on the audio, one of the things Mishka said is, he was talking about himself here. He said, I don't feel like I'm doing enough. Okay. And yet, I think any objective observer would say that Mishka is doing far more than the average physician. And as he said, he's privileged to be able to be in that position because he has some availability in his life to follow people to court. I think it's interesting to point out that there's no limit to the amount that we need to do. And so the question, of course, is where do we draw a line in our own personal lives about how we're going to contribute to addressing these inequities? And that's a personal choice. But I think that there's a minimum we can do, which is to do no harm in the interactions that we have with our patients when that door is closed in the sort of metaphorical sense. And we can even do a little better than that. We can care. And I think that most physicians are not going to go out and try to change society, not because they shouldn't, but because that's not who they are. They have other things they're doing. But what all clinicians have in common is that they care for patients. They do go into an exam room. They do close the door. And during that time, they can care and they can not do harm. They cannot be bamboozled by all of these forces out there that are manipulating our behavior through paranoia, through misinformation. And they can sit down and they can try to problem solve with that person. To me, maybe that's the message. And then it's up to everyone to decide what they want to do beyond that. That's a personal choice.
I'm curious, Mishka, what you think. What would you add to what Saul said?
So I think we're also talking, though, about like how this work is not just the bedside and is embedded within structures of oppression and historical forces, as mentioned, structural racism, structural sexism, and in particular, kind of like the role, and we haven't even talked about this, but the role of separating families and removing children as an expression of political authority, which we saw both in the genocidal campaigns against American Indians and the school, like the boarding schools. That was an attempt by separating children. We were going to, destroy indigenous culture. It's also like one of the core principles of chattel slavery, and was honestly also one of the strongest arguments for abolition was the recognition that in the images of enslaved women's children being torn from them for sale. It's been the work of other cultures and other histories too, this child separation. It is in some ways, I think Lisa Sangoy said this in one of the Movement for Family Power pieces, it's like the ultimate authority that a state can have of separating children. So what do I think needs to be done? I think we need to tune into your clinical empathy. Focus on, these things that we consider to be soft. Don't categorically elevate the things that are hard, i.e. a drug test result, over something that's softer, wishy-washier, the conversation you have with somebody, those sorts of things. More importantly, learn. The people we serve are incredible sources of knowledge and experience that can enrich our existence and our ability to care for other people too. In thinking about ways to involve people all the peer movement, but people in recovery into processes, but also thinking about all of the different other ways people's lives and experiences can really be helpful, are central to the development of hospital-based policies or public health enterprises.
Yeah.
So I think we need to be critical of what information we collect, how we share it, be transparent with patients about what we can control, what we can't control, and perhaps most importantly, be aware of how care has become carceral, especially around birth, but in other domains of healthcare as well, and think about how we can decriminalize healthcare.
Yeah.
How do we make the care not carceral?
Yeah. So I think one of my take homes here is that, first of all, I'm going to be very careful with both how I ask and how I record and information that I solicit from people, recognizing that when I close the door so that it's just me and the patient, I'm going to have to bear some discomfort, which is that the door is not 100% closed. And I'm going to live with that. And I think I need to be aware of it so that I do the right thing for the patient, actually, even if it is a bit uncomfortable. Saul, do you want the last word?
Well, thank you, Mishka. I really appreciate your meeting with us and talking about this. I think that the final words that you just shared with us, I process as saying that there is no clear line you can draw between that one-on-one problem-solving doctor-patient relationship and the larger themes that are at play here, the larger issues, the larger forces, and the larger pressures, and the larger responsibilities that we have as physicians. There isn't quite a clear line that one can draw. And I wish I could talk to you so much longer, but I really appreciate at least dipping our toes into this critically important topic, and one that I think is central to the theme of On Becoming a Healer.
Thanks so much, Mishka.
Thank you so much for having me.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.